Good evening, everyone, and thank you for joining us. We're here tonight to talk about MS with Dr. Ryan Kammeyer. I'm Kelsey Morrow, Education Manager at the Rocky Mountain MS Center. I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Biogen, Genentech, Novartis, Sanofi, and Bristol Myers Squibb. This speaker series is just one piece of our educational programming. We have a variety of formats available to you, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. This is where you can find our most recent education summit from November 8th. We had presentations on managing MS fatigue, understanding the impacts of comorbidities on MS, research updates, and AI in the field of neurology. We announce all of our educational opportunities through our mailing list, our Facebook page, and also you can sign up for notifications through Eventbrite. And now I'd like to introduce you to Dr. Ryan Kammeyer. Dr. Kammeyer completed medical school at the Indiana School of Medicine, a child neurology residency, and a neuroimmunology fellowship at Children's Hospital Colorado and the University of Colorado. He is an assistant professor of neurology and pediatrics and sees both adult and pediatric patients. His research interests include improving the differentiation of autoimmune and infectious encephalitis through clinical features, evaluation of biomarkers of disease activity in autoimmune encephalitis with Dr. Amanda Piquet, and evaluation of rheumatologic diseases such as neuropsychiatric lupus, with a goal of improving diagnosis, prevention, and treatment of these rare diseases. We have had a lot of questions submitted at registration. We'll get to as many of them as we can. We will group similar questions together, and we're unable to answer questions that are super specific to one person's experience. But you can also ask new questions by typing them in the chat box. And just remember that today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. With that, I'll turn it over to Dr. Kammeyer.
Thank you, Kelsey. Thank you all for being here. Thank you all for joining this and for all the interesting questions that people have already submitted. As Kelsey said, we've tried to group some of them into kind of categories that are similar so that hopefully the topics kind of go along together. Some questions that are very similar, we combine together. And, you know, a number of these topics could or have been their own like hour-long talks before. So I might refer a lot to prior Rocky Mountain MS Center education talks or education summits and like videos that they already have online. Some of those you might be able to get kind of even more detailed information than what we go through today. So if some of my answers are on the shorter side, it's probably because there's a longer talk out there that will go through in a lot more detail. As it was mentioned, Val, the interpreter, will be interpreting for people wanting to hear in Spanish. I usually don't talk that fast, but I'm going to try to talk kind of slow so that she's also able to help with the interpretation for everyone. So my first set of topics that we grouped together was on kind of long-term, what are kind of the outcomes, what to expect with multiple sclerosis. And so there's some really good questions in this. One of these is one that comes up a lot when I work with pediatric patients. So do people with MS still obtain demanding degrees like PhDs, or is it advised to prevent being in depressing roles? And I like this question for a few different reasons. So one, persons with MS definitely can and do obtain advanced degrees. And so, you know, I think that's if something that you're interested in, if that's something that you're passionate about, that gives you energy and joy, like it's definitely worth doing. I also like that they thought of PhD as a depressing role. You know, I think it's something that, again, if it's something that brings you joy, if it's something that brings you an interest, like it can be worth doing. I think kind of one of the parts of their question is, you know, when you're in those sorts of roles, there can be a lot of stress, or there, you know, can be a lot of like ups and downs. And I think it's true that there are things that cause physical or mental stress that can cause MS symptoms to recur. Or for some people with their MS, their fatigue or their other MS symptoms can be sensitive to those types of stressors, physical or mental. And so, just in general, it's always good to ensure that you have good supports, good mental health care, but it's not something to avoid doing if it's something that you would be passionate about and something that would give you joy and energy. Next question that's in this topic is asking about disabilities, and it's asking about if is describing someone who had something that was affecting them kind of years later. And so what's considered a disability with multiple sclerosis, and then how do you gauge it? And so for a disability can encompass a lot of different things. So it's often defined as a physical or mental impairment that limits your major life activities. And so that could be that makes it more difficult to work or care for yourself, walking or doing like manual tasks with your hands, or even learning and concentrating. Um, I feel like there's been Rocky Mountain MS Center talks kind of on this in the past. And so there may be some videos to look at after this as well. Physical disabilities are more often assessed and focused on in treatment studies in MS. So there are certain scales that we use to kind of gauge or measure it. One of them is called the Expanded Disability Status Scale, the EDSS. And I definitely know that we've had talks about that in treatment studies in the past. And this assesses different areas like strength, balance, eye movements, sensation, bowel bladder, vision, walking, and cognition. So encompasses a lot of the different symptoms that you can have with MS, especially when you have a flare or progression. But as you can tell from that list, like it's much more weighted towards physical disabilities. There is a push towards evaluating fatigue and cognition more specifically in MS treatment studies. But it's not something that the pharmaceutical companies have taken up too much on, at least as kind of their primary thing, just because there's a lot of different things that can affect fatigue and cognition that are unrelated to MS too, like mood, stress, sleep, and so not just inflammation, whereas some of those physical symptoms might be more related to inflammation, and that's why they get focused on more with the pharmaceutical treatment studies. Another great question was, what are some communication skills that are effective with your loved ones? And I think this is kind of wondering about different strategies for talking with their loved ones about MS. It's not uncommon to have difficulty talking about MS with your loved ones, or having them kind of really understand what you might be going through. It's a difficult thing to explain, and honestly, it can get fatiguing to try to do with family and friends, especially if you're having to kind of redo it and trying to help them re-understand. Um, I think a couple times ago, there was an educational summit talk that I was a part of on the invisible symptoms of MS. And in that, I interviewed one of my friends with MS. And that was one of the things that she expressed kind of difficulty with as well. I think she gave a little bit of what she found to be useful. I think some education is always good. And so some of the ways that you might be able to help in communication with your loved ones about MS is if you're able to get them to spend some time on the different education that the Rocky Mountain MS Center provides, MS 101, or the other videos. I think that's a good first step. It also helps take away some of the burden that you might feel on educating them off of your shoulders. Let the videos and let us and others kind of help do some of that work. In a similar way, like some people like to have their loved ones at their office visits, partly because they want to be there for decisions or support, especially when you're starting to have a diagnosis. But sometimes it's also easier to have their family members there because then you don't have to try to explain it and all the discussions and recap all of those to them afterwards. So again, there's different ways to involve your loved ones in kind of the education and in the clinical side of things that might help with them being able to understand more and better. Another great question was, is MS terminating in a sense like cancer? And we don't think of MS like a terminal disease like cancer. In cancer, there's a big focus on survival rates. So whenever we hear about different treatments for cancer, it's, survival over 1 year, 5 years, 10 years. And this is different than in MS. In MS, survival rates are very similar to people without MS. And so a lot of times we focus more on quality of life and indirectly, like what a lot of the pharmaceutical trials are measuring is kind of relapse, progression, and that sort of as kind of an indirect marker of quality of life. But so that's kind of more of the focus, and a lot of the studies that researchers do, that clinicians are part of, that aren't pharmaceutical related, are more focused on quality of life through like symptoms as well, and trying to find ways to improve that while having MS. And then kind of the last one is part of this topic area was just someone looking for information on secondary progressive MS. There's definitely lots of educational summits on this and videos on this. But secondary progressive MS, to think about it kind of shortly and broadly, is where your MS disease starts as having flares and relapses. So events and symptoms that kind of build over days to weeks, usually remain there for weeks to months, and then start to improve. That can be vision, weakness, numbness, balance, and then you kind of have those ups and downs for a time. And then usually years later, there's progressive symptoms. And this is where maybe over the course of a year or more, things just kind of gradually worsen, especially like weakness worsens, walking. We see it a lot in kind of the lower extremities. And you see that happen even without having new flares, new MRI changes that are related. For secondary progressive MS, we think about it a little bit differently in terms of the treatments that might be most helpful for it. There's a few medications that have been FDA approved for treating this. One of them is siponimod, another is cladribine, and then everyone's favorite ocrelizumab are kind of three of the main ones. And then there's another one, tolebrutinib, that Dr. Alvarez has given prior talks about. And that, I believe, has an FDA review that should conclude sometime in the next month. If not this next month, then kind of early this next year. And so might have kind of a fourth option coming here soon. All right. So next topic area was on symptom management for MS. So there's a kind of few sets of different symptoms. So one person asked about kind of some big symptoms as being extreme heat intolerance and fatigue, and then also dizziness, and was wondering if there was any breakthroughs on the horizon in treating those symptoms. And I honestly don't know of any breakthroughs for helping with those. I do know that there's different methods that I've seen people try using and that can be helpful. So some of these for fatigue, diet and exercise, stress management, sleep, kind of all the things that normally keep your body generally healthy also help a lot with fatigue. Sometimes we use different medicines, and I think we'll talk about that a little bit later as well. But honestly, like those first few things, like keeping your body generally healthy, is some of the best things you can do for the fatigue. When it's not enough, that's when we will try those medicines. For heat intolerance, again, different people have different strategies, but I've seen some people use cooling neck wraps to help kind of cool the blood in their neck. I've seen some people use cooling vests. I've seen some people just have extra awareness of kind of the heat and weather outside. But there are some things to kind of address it when you can't control the weather or what you're about to do in the weather. And then the dizziness, usually kind of some mixture of the above, depending on the type of dizziness. It might involve hydration, and it might also involve thinking through other causes of dizziness. So there are some types of dizziness that are related to MS, and there's some types that aren't. And they all have kind of different causes and different treatments depending on what it kind is what. Um, Another person asked about having autonomic temperature dysfunction that was causing their feet and legs to feel cold or icy without any changes in color, without any swelling, or without any actual skin temperature changes. And so, for people who haven't heard this term before, the autonomic is the nerves in your body that go to and control things that you don't have conscious thought over. So some examples of this are the nerves that go to your stomach and help with your digestion. Like your digestion is always like your stomach, your intestines are constantly squeezing and controlling kind of the movement of things through your digestive system. And you don't have to think about that consciously. The other things are like changing the size of your pupils, um, regulating your blood pressure through as you like stand up, sit down, like that does a lot. And then sweating, temperature, kind of all those things can do it as well. I think one thing to think about with this when you're kind of feeling cold, icy sensations without kind of like having any like actual temperature change in the air or on the skin is wondering like, is it the autonomic part of things or is it kind of the sensation part of things? So I've sometimes seen people when they've had, especially when they've had numbness from MS in certain areas before, where like the sensation of temperature can feel off, not just numb, but sometimes it feels like cold or icy or burning. And so you're kind of getting these sensations that are way out of the norm and sometimes can like spike in different ways. If that's true, and if it's painful, gabapentin is one of the medicines that we use that can be helpful. We have a few other ones that we use that help to try to re-regulate some of the signaling that might be going on. And then there's certain topical creams that might help as well. Capsaicin kind of gives a more of a burning heat sensation that might balance it out. And so there might be different strategies to help with that. And so, it's definitely worth talking about with your doctor, having them examine things and try to figure out like what might be the underlying cause to figure out what the best treatments might be if it is causing a lot of pain or discomfort. Next question is a really great one that I think even we can struggle with as well. So this question is asking, how do you know when new or other health challenges arise, if they're symptoms of MS or not? And they express some frustration on like different primary care doctors or other specialists saying that things are from your MS, and then later on finding that it was something else going on. And this can be difficult. So there are some symptoms that are common in MS, and there are some symptoms of MS that overlap a lot of other diseases. So, some of them we've already talked about, like fatigue, cognitive symptoms, thinking symptoms. Like those can be symptoms of many different things. Like I said earlier, kind of things that might stress your body or stress your mind can sometimes cause some of those symptoms as well. And there's a lot of medical diseases that can do it. So I think it's always good to have an open discussion both with your neurologist to see like, hey, could this be from MS? Is it something that you commonly see with MS or not? I get those questions a lot. Like, is this something that's, you know, common for MS? Is it something I should be looking at differently? And then also to involve your, primary care doctor, your other specialists, And sometimes it's helpful to ask them like, hey, if I didn't have MS, how would you be evaluating this? How would you be thinking about this? And that way they're not just saying, this is definitely from your MS, that they're kind of thinking about it a little bit more in depth. And hopefully between the two of us, from using kind of information from your neurologist on is this something common or not, and then your primary care doctor thinking about like what would it be if it was an MS, and hopefully we can usually help disentangle like what might be MS or something else that needs its own treatments or might be serious in a different way. Um, Next question is, talking about menopause symptoms and kind of early menopause symptoms since the age of 30. Um, is that a normal thing? I'll be honest, it's not something that I often treat or evaluate. Did find some studies looking at this that some perimenopausal symptoms can start early 30s. But depending on what the symptoms are, like fatigue or mood changes or brain fog or sleep, like we just mentioned in the last question, they may or may not be related to MS as well. And that can be difficult to tease out. So I think this, depending on what those symptoms might be that you're experiencing, it might be good to have your neurologist, your primary care doctor, like both kind of think about it in different ways and hopefully be able to converge on what's going on. Um, Another question is, are there any treatments for slurring or slow speech in addition to typical speech therapy sessions? And related, like, do speech issues fluctuate similar to relapsing remitting symptoms? And I honestly don't know of other specific treatments for slurring or slow speech. Um, I can say that speech issues can definitely fluctuate. Usually if it's related to a new flare, like a new relapse, like we talked about earlier, I'd expect it to be something that would be kind of gradually worsening over days to weeks, persist, and then usually have like a new MRI lesion in a specific place that is kind of controlling the nerves going to your mouth, or to your balance centers, which is also involved with speech. But like I said earlier as well, especially in persons who maybe had speech issues from their MS in the past, if there are things that are causing physical stress, mental stress like illness, fatigue, poor sleep, all those can cause either prior or mild speech issues to worsen. And usually kind of whatever that, physical, mental stress is removed, then it usually starts to improve. And so sometimes that's a way to tell, also too, hey, is this related to like new MS activity, or is this kind of ups and downs from like injury that had been there before and my prior symptoms? Um, so, in kind of last question for this section, this topic, are there any new modalities or treatments to help with difficulty walking? And for this person, their walking has been slowly getting worse over time, and they weren't sure what to do to try to preserve what they have. And it, not sure about things that are new for difficulty walking. Most of the ones I know of have been around for at least a few years. But there are a number of different things out there. And again, I think there have been talks about this in the past in different videos that can go into these more in depth. But just go through like generally um, physical therapy and exercise, probably things that you're already doing. But these are some things that um, I've sometimes seen be helpful when there's kind of a question of progression or not. And something had happened. This happened during kind of COVID when it was starting, is people kind of having less activity than they would normally, and then they're kind of walking starting to kind of get worse because they weren't as active as they were previously. And once we were able to restart kind of physical therapy or their usual exercise programs, then they were able to improve things again. Um, Depending on if there's specific weakness in areas, there's supportive devices like ankle foot orthotics or ankle knee orthotics. Um, Other people with foot drop, there's something called functional electrical stimulation devices that can be worn around the knee that help with clearing and helping your foot strength. And then if there's spasticity, that's tightness of the muscles that kind of is counterproductive and makes it difficult to walk like you should. There's different Botox or anti-spasticity, anti like stiffness, muscles relaxant agents that can be helpful. If it seems like the walking difficulties that are slowly changing are, more related to progression rather than one of those other things, there are some immune therapies that may help slow or preserve kind of your walking. And so we've talked about some of them so far. Ocrelizumab is one kind of for primary progressive, secondary progressive. And we talked about some of the other ones for secondary progressive already. One thing that I will sometimes also try is, especially if there's weakness in the legs, some people find benefit with things like Ampyra, dalfampridine, which is always tough to say, but you just say it confidently and everyone assumes that you're saying it right. It's a doctor trick. We don't actually know how to say most of the meds that we use, but we just say it confidently. As long as you don't stumble over it, everyone thinks that you're saying it right. So this is a medicine that helps with conduction through the nerves. So especially if there's been injury like from demyelination, where the covering of the nerves has unwrapped and hopefully been mostly repaired, but maybe not all the way. That kind of slows down some of the conduction of electricity from your brain down to your legs. And so this medicine is something that helps to speed up that conduction. And so for some people, if there's difficulty with walking and it's related to weakness and that can help with getting those signals down and help give some strength and extra speed. And so it's worth talking about. It works for some people. It doesn't work for everyone, but I think it's definitely worth looking at if you haven't tried it. All right. So next topic area is on disease-modifying treatments. Another term for this is immunotherapy for people who have multiple sclerosis. So one question was about Tecfidera or dimethyl fumarate. This is one of the oral treatments for multiple sclerosis. And this person was wondering about the long-term use of it. Like, what's the chance of having PML? And for people who haven't heard PML before, that's progressive multifocal leukoencephalopathy. This is where you have a certain virus. Most people have this virus, have been exposed to it before, called the JC virus. Most of us have antibodies against that virus in our system. But if you have those antibodies, if you've been exposed to that virus before, then certain of our medicines, just in how they work, can increase the risk of having a kind of serious, very rare, like brain infection occur, and that's PML. It's something that's very rare. There's been very few people that I know of who've had it, like in Colorado. And for people specifically taking the Tecfidera, what I could find is about 2 in every 100,000 people who would be taking Tecfidera might have that. And there are some risk factors that increase the risk. And so some of the things that we watch for, like older age, like greater than 54 is one risk factor that they found. And then low lymphocytes. And lymphocytes are kind of a subset of your white blood cells. They kind of are involved in a lot of things with multiple sclerosis. A lot of our treatments kind of work on them to help calm down the inflammation with MS. But if you're taking the Tecfidera and if those levels kind of stay too low for too long, then that can start to increase the chances. So oftentimes when we're doing our monitoring blood labs for Tecfidera, that's one of the things that we're watching most closely on is the white blood cell counts, and especially those lymphocytes. And if those stay too low for too long, then we consider like, should we stop the Tecfidera? It's still a rare chance of having that PML happen, but then we start to have those discussions more on if we should, if there's other options that we could do. Next question is about rituximab, and is asking is rituximab an infusion treatment like chemotherapy? And there are definitely lots of videos on this. So other very long talks on rituximab, but rituximab is an infusion treatment. But unlike chemotherapy, or at least how I think of chemotherapy, it works a lot more selectively. So the side effects are not going to be the same as you usually think of with chemotherapies. So rituximab specifically works on B cells. And so B cells are, we talked about lymphocytes before as being a subset of white blood cells. B cells are another subset of those lymphocytes. So they're a subset of your white blood cells. And those are thought to be some of the ringleaders in MS and some of the cells that are responsible for renewing the cycles of inflammation for relapses in particular. And that's why rituximab, ocrelizumab, Kesimpta, like all of those medicines are some of our most effective at preventing relapses and currently most effective for helping with progression in multiple sclerosis is because these treatments are focused on removing those B cells from your blood so that you're not having those cycles of inflammation renew. And because it allows all those other parts of your white blood cells to hang out and not be affected at all, you still have a good immune system for helping fighting off infections. Next question is asking for the latest information regarding aging with multiple sclerosis. And so specifically about disease-modifying therapy discontinuation, which is always a great topic. And kind of specifically, like, does it make sense to continue certain medicines if you're not seeing any new MRI issues, nothing showing up on MRIs, no kind of new relapses, no progression. And so this is a topic area that's still ongoing. Lots of research is still being done with this. There's still several clinical trials that are doing this. And Dr. Corboy has talked about his DiscoMS study and some of the extension of that on prior videos. What I could find that's kind of beyond Dr. Corboy's is that recently there was a meta-analysis, which is where they take a number of different studies, a number of different articles that have been on this topic, and try to pool them together and try to find, either statistics or trying to find common features for those studies to help kind of answer these questions. And so one of the ones I saw recently had 22 articles, 22 different studies that were trying to answer these questions. Some of them were very recent, like in the last year or so. Some of them were farther back. And together it was about 3,000 patients. It's a little bit difficult to compare between studies because every study tends to use different age cutoffs on when they consider like stopping disease-modifying therapy. And then also different criteria for when they count someone's disease as being stable and safe to try off of therapy. So from this analysis, this meta-analysis, one of the things that they found was your risk of having a relapse was less than 1% per year if you were older than age 60, and if you had been on treatment for at least 10 years or had 8 years of kind of disease being stable, so MRIs not changing, no progression, no relapses. And they found that the risk was greatest if you stopped kind of two treatments in particular, like a risk of a relapse, natalizumab or fingolimod, so Tysabri or Gilenya are kind of the other names for those. And we actually know already that both of those, when you stop those, there's a risk for rebound flares. So it's something that we usually find a different medicine to switch to if we're needing to stop those for some reason. There was one trial that was looking at discontinuation that ended up being stopped early. So where multiple people had relapses when they discontinued. Those people were all averaged age less than 50, as opposed to some of the other studies, including Dr. Corboy's studies, where people were, at least 55. I think average was older than 60. And so I think our clinical practice, we will likely still continue discussing discontinuation and like what it would look like with close MRI monitoring for people who are over the age of 55. And for me personally, like I talk about it with people who are 55 or older, and if they've had like stable MRIs, like no relapses for 5 years or more. And I think over time we'll kind of keep gathering more and more information from these trials on, do we can we do younger ages? What's kind of the right level to say, hey, this is stable, and in what type of treatments too? Some of our treatments are um, kind of less effective at preventing relapses. Some of them are more effective. And does that make a difference if you're, stable for 5 years on a less effective medicine? So the medicine maybe didn't have to do as much and says your disease is less active already versus one of those more effective medicines where, it may be more difficult to tell like where the underlying disease is at. And so again, more information to come in future years and lots of good videos and information from some of Dr. Corboy's prior talks. Another question was on the trials and therapies for relapse and remitting MS versus primary progressive, and why are there always more for relapse and remitting than primary progressive? And I think there's a few different reasons for it. Doesn't mean that's fair. And like primary progressive MS is one of the forms of MS that really needs and more treatment options and more therapies. And so it should have more of a focus. But I think some of the reasons that I could see is that relapsing remitting MS is more common overall. I think sometimes it's easier to come up with outcomes in like a trial. And so people tend to gravitate more towards relapsing remitting in their studies because it can be easier to say, number of flares, number of MRI changes, rather than like progression. And the causes of MS for relapsing and remitting MS are, I think, generally more understood. There's still a lot of debate on kind of what are some of the reasons why primary progressive or secondary progressive MS happens, how much of it is related to inflammation, and how much of it is from like other kind of underlying causes or side effects of the inflammation. And so there's also a lot of talks on that go into depth on that. But I think because of kind of the frequency, the outcomes, and the causes, that might be why there's more that's focused on relapsing remitting. But you're right, there's a lot that needs to be done and that should be done for primary progressive. In a similar way, like a different person asked, like, what's some new research or treatments focused on this? And there's a lot of them in various stages of trials that all kind of work in different ways. One that I think we're all very interested in is something called CAR T therapy. And Dr. Piquet has done, I think, some talks on this in the past as well. And this is a treatment where they kind of harvest your own T cells, which is a different type of lymphocyte. So we have the B cells before, the T cells are a different type of your white blood cell. And these cells, you can take them from someone, you can reprogram them to attack other immune cells in the body. And so they take your own cells, they reprogram them, and then they put them back into your body. And then they can go through and attack kind of specific immune cells, sometimes more broadly than what we can with rituximab or ocrelizumab. And usually those cells can go and kind of go throughout your body and maybe have a more long-lasting or more complete response because they can reach deeper into the brain or the spine to help with inflammation there. And this has been used very successfully in some other autoimmune diseases. It's still an early therapy. I think most of them are still kind of in their early phases of treatment, but it has been really effective. One downside of this is it does require some degrees of chemotherapy. It is a pretty intensive protocol, and we do have some trials on that here at university. And so it's something that we're interested in. It may not be something that's right for everyone. We may still find that as far as like risks of this versus the benefits may be reserved more for people whose disease is just not responding to our usual and standard treatments. But um, this is something that we're going to be watching pretty closely over the next years. There are, like I said, some of those other stages of trials that are kind of being looked at. None of them have clearly shown one versus another being more beneficial at this time, but there's some simvastatin, a cholesterol medicine, still has a trial going on. Metformin, which is a diabetes med, and then antioxidant alpha lipoic acid, I think has been studied a few different times, but is being studied in combination with other things. And then stem cell transplantation, the BEAT-MS study, Dr. Corboy may or may not have talked about in the past, is another one that has been looked at, especially for people whose disease is progressing or has not responded to our usual treatments.
Dr. Kammeyer, we actually have a question in the chat, kind of about stem cells and then also Tysabri. Someone has been on Tysabri for 15 years and it's working to keep their MS at bay, but their mobility is starting to decline slowly. They've been considering stem cell infusion or stopping Tysabri altogether or spreading out their infusions.
Yeah, so those are great questions. And I might have to defer a little bit to your neurologist that you work with. There's different, so stem cell transplants and stem cell infusions I think of as different. So stem cell transplants, it's usually trying to get rid of all of the immune cells that might have been misbehaving and might have started to recognize against your MS and like started your MS and trying to kind of renew those with like brand new cells that don't recognize your body, your brain, your spine as something it should be attacking. Stem cell infusions, I've seen some where people have gotten them like in their blood. I've seen some where some people have gotten them in their spinal fluid, and um, I guess I haven't seen like a big benefit with like all the patients I've seen. We've had someone end up with a very severe chronic meningitis from one of the protocols for that. And Tysabri in particular is kind of stopping your white blood cells from going into your brain and like renewing the cycles of inflammation. And so depending on how the stem cell infusion is done, it might also be harmful. So I think it's something that's worth talking about with your neurologist because there's, I think, a lot of different factors there, both on, what's the likelihood of the stem cell infusion in that protocol being helpful, what's the, potential risk with it to kind of help come to that decision. Stem cell infusions in general are something that are still being studied on trying to help, whether or not that's helpful for repair and remyelination. There's a topic area we'll talk about, I think maybe next, that is, yeah, I talked with your neurologist about that, for that specifically. Again, I haven't seen kind of stem cell infusions be as as helpful as I think we would hope they would be. But there's different protocols out there, and there's different trials I know different centers are using that I think are trying to address some of the shortcomings or some of the risks that you might have from some of the centers that do them and kind of do them off label, like off FDA approval. So it's a great question. It's one that comes up, and I think repair and helping with progression is kind of one of the other kind of big topics and one of the other big unmet needs. There's a lot of questions about repair that we'll kind of be going through as well.
And I just wanted to share we have videos on our website from both Dr. Amanda Piquet and Dr. Andrew Wolf that cover both how stem cells may be used in MS and some misconceptions and cautions when talking about stem cells.
Oh, I didn't know that Andrew had a talk on that. That's great. I would have imagined that he would have done that one. All right, so some other kind of questions. And this one is about kind of the immune system being on immunosuppressants. So this person kind of wrote in and said that they are on ocrelizumab. Their immune system is low, and what medications or supplements can I do to help increase my immune system? And in a similar kind of question, another person asked, like, I'm a teacher. There's lots of sick kids around me all the time. I teach like 300 junior high students. I wear a mask. I have my window open. If I'm on Kesimpta, which is a medicine that's kind of works similarly to ocrelizumab, just different in how you give it. How immune compromised am I on this medicine? So to kind of answer both of those, so supplements that increase the immune system, like there's a few of those that you hear of or that you see, like immune boosters, especially during winter, like the question comes up quite often. Um, they, I find that they don't often do as much as they claim in helping increase the immune system. Um, and in an autoimmune disease, like we usually think that these supplements probably aren't doing so much that they're going to cause your MS to flare, but at the same time, if you're on a medicine that's trying to lower your immune system because your immune system is overactive, and then you take a supplement to increase it, it feels like it's being a little counterproductive. So I do think that there are some things like that most people take, like zinc, vitamin C, those I think those are fine to use with an infection. Um, but some of those other supplements, again, I'm not sure how much they help, but it does make me worried that it kind of is being counterproductive or kind of might increase some things. Some of the medicines that we've talked about, the Kesimpta, which one of the people kind of asked about, ocrelizumab, which the other person asked about, and rituximab, like those are very similar medicines. Those are the ones that are working on those B cells, that kind of subset of white blood cells. On average, when you kind of look at the studies, it averages out to maybe an extra cough or cold per year. But honestly, this is really different for everyone. So I have some people who are on these medicines who never seem to get sick. Um, Even I'm getting sick way more often than them, and I don't understand why. And then there's some people where like they like start the medicines and it's pretty clear, like, okay, yeah, I'm starting to have more often these infections. Maybe I'm needing antibiotics for the infections now, and I used to not, or maybe it's taking a lot longer to kick, whatever virus or thing it is that's going around. Um, I'll say on average, like most people who are on these medicines, like aren't needing to wear masks, aren't needing to avoid like social situations. Um, but if you're feeling like you have to or that you need to, like it's good to discuss with your neurologist if there's a different medicine that could give you a different quality of life. Most of the medicines that we use do work in some way to decrease the immune system because MS is the immune system being overactive. Um, but there's options, and each kind of one has like different risks of the infections, and there's some that will have kind of a lower risk than others. Um, and so maybe one of those would allow you to, still do things more normally, or, still be able to do the things that you enjoy, or not have the worry of, those 300 germy junior high kids being close to you. Um, I have a number of teenage kids in my practice at Children's who are on these specific medicines, and they are getting into germs all the time. And they don't wear masks or really do much of anything to help with preventing things. But some of the things I impress upon them is, making sure that they're doing good hand hygiene. So that, all the different things that they're touching throughout the day, doorknobs, desks, all those things, that they're at least making sure that they're washing their hands before they eat, as and if they're having any sicknesses show up, even if they're not the type of kid that likes to go to the doctor and like see their doctor for every sickness, like it's good to check in with the doctor when there are sicknesses to make sure that there's not any signs of a sickness that would need an antibiotic or something else to help. And so I think some of those principles are useful for adults too. Like we should all be using good hand hygiene, and hopefully most of us have learned that by now. Um, and if they're, even if you're not the kind of person who likes seeing the doctor or often would go to see a doctor with a sickness, I think it makes sense to make sure that there's not something else that can be done to help out and to help keep your body safe and help kick whatever illness is going on. This last question is a very specific one for MS treatment. And so this person has MS and they also have lupus. And they take um, a specific type of infusion called Benlysta that's more used for lupus, and then chemo injections, which I'm not sure what the chemo injections are. And there's kind of wondering like thoughts on this infusion, how effective it is to treat MS. And honestly, I haven't seen anyone use Benlysta specifically for MS. Most often we use rituximab, which kind of overlaps as a treatment that works on some of the same cells that are involved with lupus, the B cells, and so it can have helpful impacts both for lupus and for MS. So that's why I've used most often in my patients who have lupus and MS or something like MS. However, Benlysta works on similar cells as the rituximab. So, again, talk with your neurologist who might know the details the best. But this might be okay as long as people are watching your MRIs, your symptoms pretty closely. It may be something that's useful. I couldn't find much on the way of like specific trials or things in the medical literature that's been published on like its use. So I can't say too much from that standpoint. Okay. Next set of questions are about the non-medicine treatments for MS. So we just went through all the different medicine treatments that are sometimes used in MS, and the questions related to that. And so now kind of talking about the non-medicine treatments. And there are things that are not related to medicine that can help with MS. We usually recommend the medicine because that's one of the things that is best at protecting like brain health, preventing like new injury, new relapses and progression. But there's a lot of other things that can help both with symptoms and with quality of life. One person asked, is dairy okay? And I think to take this even just a little bit more broadly, like there's a lot of questions that we hear about diets and exercises and just like what can I do in my daily life to help with MS? And dairy is okay for most people. I usually tell people like it's not something that you have to stop with your MS. If it's something that makes you feel unwell when you drink or eat it, like it's okay to stop it. Like you probably shouldn't be doing it. Like you might have a lactose intolerance, and And like I said before, any kind of physical stress, mental stress, if it's something that is kind of causing that stress in your body, then it might make some of your MS symptoms worse. But for most people, like dairy is okay. And what we know and what's kind of been shown the most is that a generally healthy diet, so kind of lots of fruits, vegetables, like lower on like processed foods, maybe lower on like fats and sugars if you're able. Um, the Mediterranean diet is like one that we've talked about in prior talks, and that also kind of like helps protect against brain atrophy just in general, brain loss, and even in people without MS. Um, so that can be a good framework, Mediterranean diet. Probably read online, there's a few different diets that people advance specifically for autoimmune diseases or for MS, like the Walls diet. Those haven't been shown to necessarily be better than just having a generally healthy diet. There, I think, is a trial going on that is looking specifically at the Walls diet and trying to compare to not doing the Walls diet. And that one might help kind of answer that question more on if all the specifics of the Walls diet are kind of helping more than a generally healthy diet. Um, but in general, I tell people like, think through like what would you normally think is a healthy diet? Use some of these different frameworks if they're helpful to you. And then what are you able to do long term? And what makes you feel better? Like if kind of doing a particular diet makes you miserable because you're not able to kind of eat the things that give you the most enjoyment, then that might not be worth it. Um, but if there's a diet that you're like, I can stick with this, like this makes me feel healthy, like I'm happy to be doing it. This kind of gives me extra motivation to do this diet that I've been, wanting to do for a while, then I think that's maybe the best diet for you and for your body. The other thing that I like to talk about is exercise, and we'll talk about this a little bit, in other topics as well. But exercise is great for your general health. It's great for your MS. Like it helps with decreasing like inflammation, just like a healthy diet can. It helps kind of build up your strength, your stamina, kind of all the things. It can help with fatigue, helps with cognition, can help with sleep. Like those are probably two of the core things. And we did a survey study. So earlier, Kelsey said like a lot of different research things I'm involved with, but we also do research and have kind of worked on different survey studies with people who have MS. And one of the things that we kind of looked at here recently was what are some of the things that people want more support in or kind of more education on? And diet, exercise, like making lifestyle changes, ways to do that successfully was like the two largest things. Like 50% of people wanted more education, more support in those things. And so those are kind of a big topic area. And one of the reasons why I think there's usually some mention or some topics on that at like most of our education summits that come up. Um, the next question kind of answered some of that already, but the next question is talking about how to manage like MS fatigue. And so this kind of gets to the symptoms again, and just like what are the most effective strategies for this? Lifestyle changes, exercise, medications. Um, I would say there's a clinical trial not too long ago, in the last 10 years, that kind of looked at some of the different medications and that are used to treat MS fatigue. And it looked at that compared to placebo, so just essentially sugar pills. And overall, there wasn't a big difference in like some of the common medications we use, like Provigil, amantadine, and like some ADHD related medications like Adderall. Um, and kind of looking at those, like I said, there wasn't a big difference. I mean, that was overall. And so, kind of averaging across all different people. Um, but some people still swear by these medications and like can feel that there's a big difference whenever they take them. And but because of that trial, and because knowing that like they don't have as big of a role in managing MS fatigue as maybe they did in the past. Some of the things we talked about before, the things that help generally with health are things that help with fatigue, both inside and outside of MS. So the healthy diet, exercise, stress management, good sleep, mood, like all those things are things that probably help the most with fatigue and probably do more than some of the medications. So for that reasons, like I usually recommend trying those first, kind of doing as much as you're able to with those. And then sometimes if like despite all that, like there's still a lot of fatigue, it's causing a lot of issues with work or with activities. And sometimes we'll try all the medicines. What I usually hear is more of them taking the edge off rather than being like a game changer or removing it completely. And so it's something that helps, but those other things I think are what helps the most. There are different studies that are going on trying to find other ways to address like MS fatigue through medicines or different strategies and different programs. But those are some of the things that we have available right now.
We had a question from the chat. What supplements do you suggest for MS patients overall?
Um, I think as far as supplements go, I still check. Vitamin D is one that's kind of gone back and forth in the years on like how important it is to helping with MS, to helping against prevent relapses or disease activity or things like that. There's been different studies kind of showing it as maybe being related to fatigue in different ways, both in MS and other autoimmune diseases. Um, I personally still check like vitamin D levels. I still try to keep vitamin D in normal ranges for people. If you go too high with your vitamin D, then that can start to wear on your bones, kind of opposite of what most people think of for vitamin D, but it can start to wear things down. And so I'll usually check that. And so vitamin D is probably the main supplement. Um, there's not any other supplements that we've shown as like this is definitely the thing that everyone must take or that needs to take. Even vitamin D, like I said, it's not always like not everyone I think would do what I do. I There's a lot of information out there, like doing reading on the internet. There's a lot of people who find different supplements that they think help with different symptoms or help with their MS. And um, I don't discount that. Like there's a lot that we don't know still, but a lot of them don't have the evidence for me to say like this is something everyone should take. And so I think for supplements, like if it's something that I usually talk to my patients and say, for diets and supplements, is let me know kind of what you're thinking of and kind of talk with me about them so that we can talk about like, does this make sense for you specifically, your symptoms? Um, what's Is there any potential risks for it? So there's some supplements that can be more risky, or like I said earlier, it could be counterproductive in like boosting your immune system, and we're not trying to do that in a lot of kind of our treatment of MS. Um, so kind of check with us to make sure that's safe and that it's not something that is like going to cost a lot. There's certain supplements, there's certain things that are advertised that cost a decent amount or can add up over time. And I don't want people to be like spending thousands of dollars for something if like there's not good evidence, if like it's not something that has really been shown to be helpful aside from like some people's experiences. But if it seems like it's safe, if it seems like it's not going to cost a lot, like I think it's definitely fine to try and to try if it's something that you're interested in. So hopefully that kind of answers your question. It's, you know, not usually ones that I can recommend to everyone, but just things to keep us in the loop. And some of the things that I talked about earlier, like the alpha lipoic acid, there are other supplements, other things that are still being in trials to try to get that evidence for like, oh yeah, this is definitely something that helps with repair, or this is really something that helps with progression, or this really does help, decrease inflammation. Um, those studies are still going on, just like the diet studies. Um, the Another question on this is actually not sure why I put this under the non-medication treatment section, but there's a question on, why aren't there as many studies on MS as there are other chronic diseases? Um, and why does it seem like more women develop this disease, develop MS? And honestly, I think there are a lot of studies on MS, at least in proportion to how rare it is compared to some of the other chronic diseases. Like, it depends on what you're kind of meaning by chronic diseases. There's some diseases like hypertension, diabetes, like those affect a huge number of people. In MS, although there's a number of people with it, as kind of evidenced by all the people that the Rocky Mountain MS Center like works with. Um, it's not as common as kind of diabetes and those others. And so, I think there's still a lot of interest. It's like one of the most studied like neuroimmune diseases. So like one of the ones that like I and the others at University Hospital like see and treat. Um, and so I think there's still a lot of interest and momentum on trying to figure out ways to help with it, to help with some of those areas that we still don't have the best treatments for, fatigue, non-medicine treatments, progression. There's a lot of studies that are still going on for those. As far as like why more women develop this disease, I don't want to bore people with all these different details, and maybe this has been a topic at some point in the past that I don't remember, but women in general are more likely than men to develop autoimmune disease. So autoimmune disease being where MS is one of those autoimmune diseases. Um, Autoimmune disease is where your immune system that is supposed to be fighting against infections is starting to fight against your own body and the cells or the tissues in your own body. And for MS, that's the brain, the spine, that those cells, the immune system are starting to fight against. And there's different thoughts for why this occurs. Um, One, it's thought that women might have more robust gene expression. So the genes like in their cells that are related to the immune system are kind of produce more, are stronger, produce more of immune related proteins that higher levels of estrogen might enhance immune system function as well. And so in some people might kind of push it too far, enhance it too far into where it gets into autoimmunity. There's greater levels of antibodies in women that might be related. And then there's certain proteins on the X chromosome that might also kind of result in production of autoantibodies. And so there's a few different reasons for why that is thought to happen, but it's something that's not just seen in MS, but also more broadly. I think one thing that's interesting is for kind of autoimmune diseases, again, I see kids as well. In kids, like there's usually not as much women um, there's not as high as of a rate of women or I guess, teenage girls at that point getting the disease compared to, teenage boys. Um, it tends to be a little bit more equal, both for multiple sclerosis, lupus, and some other autoimmune diseases. And so there is kind of some changes over time that happen. And kind of after people kind of get into like later teenage years and like, adulthood, that's when it starts to be much more women predominant who get diagnosed with this. So it's a great question. All right, a few more questions on kind of a very important topic, like what are things that can be done to help repair MS? And remyelination is, kind of the word that is used most often in describing this. Um, So one question is, what's kind of new on this? Like, what progress has been made most recently on remyelination, healing old damage, and trying to help with disability? And as mentioned earlier, there's been talks about the stem cell infusions and stem cell treatments that have been looked at or that are sometimes advocated for. There's a study that I think Dr. Bennett is still enrolling for on vagus nerve stimulation, like one of the nerves that kind of goes through your neck and kind of innervates different things in your torso, goes up to your brainstem. And there's been some studies where like stimulating that with like some pulses on your neck might help with kind of re-stimulating remyelination and function. That study was looking specifically at people who are having difficulties with hand movements. I think there's some links to that on the CU Neurology like research site that you would be able to take a look at and see if that's something that's still going on and something that you're interested in. And then there's many trials still ongoing and different ones like clemastine, metformin, we talked about before as like a diabetes med that's being really investigated for progression and for remyelination. Crystalline gold, something that I've heard of, and I'm not sure what trials, what stage they're in currently, but another thing that I know has been looked at. And I believe we have some talks on those as well, kind of going into those specifically from kind of prior educational summits. In a similar way, one person asked, the MS that they had unfortunately caused them to be legally blind and wondering specifically about like what are ways to restore the optic nerve. In addition to those remyelinating studies, I know that Dr. Bennett has either been involved or had tried to start some studies in the past that was looking at some electrical stimulation devices that were kind of specific for the optic nerve and trying to kind of make signaling go back and forth along those with the hope that that is going to be able to help with remyelination. And I don't remember too much about that other than, as part of a proposal that he had put in a couple years ago. And so there are things that are being looked at, not just for remyelination in general in MS, but also looking kind of more specifically at the optic nerve. And there's a few other kind of questions on kind of this similarly. So one was asking specifically about nerve stimulation to help treat MS nerve damage, and kind of asking about the vagus nerve. And another one kind of asking like, what are other ways to help kind of heal as best as possible? And hopefully kind of like those, and what I mentioned earlier about the remyelination, about those studies was also kind of helpful in answering some of those questions as well. All right, and I think we got through the different questions that were kind of submitted beforehand. Don't think I had any others. Kelsey, did you have any others from that I missed from before?
Um, I didn't catch. Did you answer the one about postpartum and potential for flare-ups after giving birth?
Oh, you're right. I don't think I
Okay.
did. I don't think where I put that. Could you perhaps
Yeah.
read the question to me just because I may be difficult for me to find it?
Yeah. I'm several weeks postpartum and understand that there's a high potential for flare-ups in the year following giving birth. Apart from continuing treatment, is there anything specific I should be doing to prevent symptoms?
No, it's a great question. Um, Continuing treatment is definitely a great thing. Um, so we know that breastfeeding actually is one of the things that like helps decrease like risk of flares as well. And you've probably talked with your neurologist about kind of the timing of everything. We'll usually kind of restart, depending on which treatment it is, we'll usually restart our treatment about a month, sometimes 2 months kind of into after birth to kind of give a little bit of time. And the breastfeeding also kind of helps protect against flares during that time, kind of especially in those first few months. I think it's tough being a new parent, and like there's a lot of stress and there's a lot of changes in your diet and a lot of changes in your exercise and a lot of changes in your sleep, especially. And so, like, whatever you can do to kind of work with your partner or people in your family to, make sure that you have some time for yourself too, and being able to do some of your own self-care, I think is going to be great for you. And that's true for anyone who has a new kid in their house, but I think it's especially important for people who have MS. And so you can tell your partner, other people that, I told you that.
And we do have one raised hand, so I'm going to go ahead and allow Dimitri to ask a question. You should be able to unmute now. It's a feature we don't use very often, so I'm not very familiar with it, but Dimitri, are you still able to ask your question? Well, we can come back to them if they come back. I don't think we had any other questions in the chat. We did have someone mention the BEAMS program, which was developed at Anschutz, and they put a link to the study on it. If anyone is interested in that, it's a balance and eye movement exercises. But otherwise, I think we covered everything fantastically tonight. Thank you, Dr. Kammeyer. Thank you, everyone, for your wonderful, wonderful questions. And I hope that everyone has a really lovely evening.
Yeah. Thank you all for joining. Thank you for your attention. And yeah, let us know if there's other questions. But thank you all for being here, and I hope you have a great night.